In this video, we will be discussing the mechanism of action and important pharmacologic considerations of bisphosphonates and their role in osteogenesis imperfecta and osteoporosis. So to start, we will first touch on bone remodeling under normal non-pathologic conditions. So I do understand that musculoskeletal disorders are not a focus of Block 3, but in order to understand bisphosphonates and their role in osteogenesis imperfecta, we will need a brief intro of bone remodeling and how this can become unbalanced. So the bone remodeling cycle is in place to handle the normal wear and tear that happens on bones as we age. So the goal of this process that we will focus on today is to preserve bone integrity. But for future reference, this process is also extremely important for mineral homeostasis. So there are two primary cell types involved in the bone remodeling process. We have osteoclasts, which are responsible for bone resorption, and these will break down old bone. And we also have the osteoblasts, which are responsible for bone formation. And these will build up new bone in those sites that were broken down. So as we age, microfractures can form in our bones. And in order to repair these microfractures, prevent further fracture, and restore that bone integrity, osteoclasts are recruited to the site of these microfractures. I will not get into the details of cellular recruitment, differentiation, or activation signals in this video, but once the osteoclasts are at the microfracture site, they can then begin the bone resorption phase and digest this bone matrix. So once this process is complete, these osteoclasts are turned off. And then following osteoblast activation and recruitment, these osteoblasts can come into this newly exposed site and deposit new bone. Under normal physiologic conditions, this is a continuous cycle where the rate of bone resorption is equivalent to the rate of bone formation, and there's no net loss. So moving to the next slide, a number of situations can tip this balance so that the rate of bone resorption is greater than the rate of bone formation. This unbalanced osteoclast-mediated bone resorption further compromises bone integrity beyond the usual wear and tear, placing those areas at increased risk for fracture. This state of compromised bone strength and risk of fracture is a heterogeneous condition known as osteoporosis. Osteoporosis can be a concern with postmenopausal women, androgen deprivation therapy in men, chronic glucocorticoid use, immobility, malignancies, whether they originate in the bone or metastasize to bone, and in the case of our patient, osteogenesis imperfecta. As you can imagine, a commonality here is all of these conditions or exposures result in a weakening of bone, so that it won't be able to withstand the normal wear and tear to the same extent, and will be more susceptible to microfractures, needing more osteoclast-mediated resorption. But this resorption will further weaken the bones until the osteoblasts are able to keep up. But if for whatever reason these osteoblasts are unable to keep up, then these pathological fractures can result. Additionally, further osteoclast-osteoblast regulation can be thrown out of balance by each of the situations that I mentioned before. So on to the next slide. To counteract this imbalance, bisphosphonates are used first line for the prevention and treatment of osteoporosis due to a variety of etiologies. So bisphosphonates are anti-resorptive agents, meaning they inhibit osteoclast-mediated bone resorption. So bisphosphonates have a very high affinity for bone because of their structure. It actually allows binding to hydroxyapatite crystals in the bone. So in order to bind bone, hydroxyapatite binding sites must be exposed, which occurs following osteoclast digestion in this bone remodeling process. So the bisphosphonates will only bind areas of active bone turnover. And this is important because remember, this is going to be where the osteoclasts are. So with bisphosphonates bound to bone, osteoclasts will be recruited to the site of bone remodeling to begin breaking down the bone matrix. But in the process, the bisphosphonates are going to be released and taken up to interfere with cholesterol biosynthesis in the osteoclasts. Specifically, the bisphosphonates are going to inhibit farnesyl pyrophosphate synthase, or FPPS, you might see it abbreviated as. And this is important for farnesylation of proteins, which is an important post-translational modification that's responsible for promoting protein membrane tethering. This impairment prevents normal cellular activities in the osteoclasts, triggering osteoclast apoptosis and inhibition of further bone resorption at this particular site. So moving to the next slide. The currently used bisphosphonates are risedronate, alendronate, abandronate, zoledronic acid, and pamidronate. And the hope is these agents will restore the balance between osteoclasts and osteoblasts and significantly reduce further bone density loss and fracture risk. Additionally, these agents are particularly unique from a pharmacokinetic perspective and provide a great opportunity to begin thinking about drug absorption and distribution and how this can impact clinical decisions in patient counseling. So let's move on to the next slide. So when drugs are administered orally, they travel to the GI tract, where they are absorbed across epithelial cell membranes to then eventually hit the bloodstream, to then be distributed throughout the body to the site of action, the site of metabolism, which is usually the liver, and eventually the site of excretion, which is usually the kidney. However, bisphosphonates act a little different. So bisphosphonates are highly polar and negatively charged because they mimic that pyrophosphate structure, which is also why it has such a high affinity for bone's hydroxyapatite matrix, which is made up of calcium and phosphate. Because they are so polar, when they are administered orally, they do not readily travel across cell membranes, and therefore it is not easily absorbed. When talking about the amount of drug administered versus the amount of drug absorbed, this fraction is known as a drug's oral bioavailability, which you may see abbreviated as F. Now remember, oral bioavailability is really just the fraction or percent of drug that's administered, PO, that actually makes it to the bloodstream. And just to put this into perspective, alendronate, for example, has a bioavailability of less than 1%. So less than 1% of that oral dose that you are giving that patient is actually making it into the bloodstream. This becomes really important from a drug interaction perspective, specifically oral co-administration of drugs with bisphosphonates. So keeping in mind that they are already poorly absorbed, remember, these agents are very negatively charged because of their pyrophosphate-like structure. This means that they will have a very high affinity for things that are positively charged. So things like calcium, aluminum, iron, magnesium, etc., even dairy products. So notably, individuals at risk of osteoporosis or those that have osteoporosis should be taking calcium supplements. So it becomes really important for patients to separate their calcium supplements and their bisphosphonates by at least 4 hours. Otherwise, the two will bind in the GI tract, chelating the drug, so neither the drug or the calcium is actually absorbed, and instead it will complex together and just be excreted via fecal elimination. This will only further make the bisphosphonate absorption unpredictable and incomplete, so it will be unclear if the patient is even benefiting from these agents. So now that we've talked about drug absorption, let's move on to distribution on the next slide. So now that we have this very tiny fraction of drug in the bloodstream, let's talk about distribution. We will use alendronate as our example bisphosphonate, and once in the bloodstream, alendronate will travel to its site of action, being the bone, and be rapidly taken up in the skeleton, because remember, it has a very high affinity for bone, and it'll get sequestered there. And whatever bisphosphonate does not make it into the bone will be rapidly excreted in the urine by the kidneys. You may be thinking that if this agent is rapidly excreted in the urine after oral administration, it must have a really short half-life. And what I mean by half-life is the time it takes for the drug concentration in the blood to drop by half. However, this is not actually the case with alendronate or the other bisphosphonates. So the kidneys may rapidly clear the blood of the bisphosphonate, so the initial plasma concentration drops. But remember, these bisphosphonates are sequestered in the bone. So there is the second compartment that is separate from the blood. And what happens is, once the blood is initially cleared, drug can leach from the bone back into the bloodstream to redistribute to refill the tank. This blood will then be cleared by the kidneys again and restart this distribution cycle over and over again. Because of this sequestration in the bone, studies have shown that biochemical markers of bone resorption inhibition actually lasts at least a year, and some suggest an apparent half-life of these agents of up to 10 years. This becomes important because with this targeted sequestration at the site of action, and this long apparent half-life, bisphosphonates do not have to be dosed daily necessarily. And this is important because they are associated with a lot of adverse GI events. Because of this and their poor absorption, the patient must take them first thing in the morning without food and at least 30 minutes before breakfast with a full glass of water and remain upright for at least 30 minutes after taking. Also, remember some of their meds, like their calcium supplement, will have to be separated by even more time. So this administration can be very inconvenient and may not be possible for a patient to do daily. And there are some IV options available, but they're not always covered by insurance. So these pharmacokinetic considerations allow us to give these agents potentially once weekly or monthly if needed. And ultimately, this would improve patient compliance and outcomes down the line. So I hope this video has provided a summary of how bisphosphonates work and how we can use their pharmacokinetics to influence patient counseling and improve compliance.